Hi, I'm Bruce Stanley. I'm happy to be here today to talk about continuous glucose monitoring. My diabetes story. About 2 years ago, I went to Italy and had a wonderful trip other than falling in the canal in Venice, which is a whole nother story. But I came home and found that I was urinating multiple times every night. I was losing weight. I was always thirsty. I started getting sicker and I kind of rode that wave for a few months, enjoyed the weight loss that I didn't have to work for. But as I get sicker and sicker, I finally had to just fess up to being a diabetic. So I tested my blood sugars and my A1C, and it was greater than 14, and I was in the 400 range. And I figured I had finally crossed the threshold to type 2 diabetes. So I started on liraglutide and also metformin and realized after a month I wasn't making any headway with my blood sugars. So I did antibody testing and found out that I indeed had two of the autoantibodies that lead to type 1 diabetes. And so I ended up starting a course of insulin glargine and insulin aspart and started the process of becoming a type 1 diabetic. Within a few months, I was able to get on a continuous glucose monitor. And then a few months after that, was able to start an insulin pump, which I am now happy to say my A1C is a 5.9 and I'm very well controlled with few hypoglycemic events.
Dr. Bruce Stanley graduated from medical school at St. Louis University in St. Louis, Missouri in 1999, and then completed his family medicine residency at McKay Porter Family Practice residency in 2002. Dr. Stanley practices at Intermountain Layton Clinic, where he has been the clinic lead since 2018. He has been a part-time faculty member at McKay Porter Family Practice since 2002 and is associated with Intermountain Layton and McKay hospitals. Dr. Stanley is also on the Utah Adult Diabetes Care Provider list. We are delighted to have Dr. Stanley with us today.
Wow, I'm excited what we can learn from you today. Thank you so much for being here. Welcome again to our wonderful podcast we have for the Ogden Surgical Medical Society. Today, we are joyed to hear from Bruce Stanley. He is a type 1 diabetic and also a physician. So he has a really good knack for understanding some of these little intricacies with glucose monitoring and monitoring of our type 1 diabetic patients as well. Bruce, what is CGM?
So CGM is continuous glucose monitoring. There's several different devices that are used, but the general term is continuous. So it is ongoing glucose monitoring.
So Dr. Stanley, I assume there's different brands out there, different companies that make these CGMs. Maybe let us know what some of those brands are and how they differ from one another.
So unfortunately, I can't really give you any generic names because there are no generics for this at this point in time, but there are four major ones on the market. The first is the Freestyle Libre Flash. Second one is the Dexcom G6. Third, Medtronic's Guardian 3 Connect. And the fourth is the Eversense. And so those are the leading latest on the market CGMs.
And Bruce, are they both to be used for type 1 and type 2, or is it just one or the other?
So they can be used for either type 1 or type 2s. Initially, they were marketed more towards the type 1s because of the need for constant monitoring of glucose levels with type 1 that tend to be more random, quickly changing targets going up and down, versus type 2s that tend to have, because they have endogenous insulin, blood sugars rise and fall at a more controlled rate. However, as time goes on and type 2s end up on insulin, they and lose their endogenous insulin production, they can be just as benefited by a CGM as a type 1 diabetic.
So I know I get a lot of questions these days from patients about getting CGMs. They don't always call it CGM, but they say this new technology where I don't have to prick my finger is oftentimes what they say. And then that leads into the obvious question of cost and whether insurance covers these or not, and kind of what the process is for getting these covered. Do you want to comment on that?
Yeah, so there certainly do have different costs associated with them. And insurance coverage, oftentimes, as it is with other medications, will dictate which one you can use. That being said, the cheapest of the four that are on the market is the Freestyle Libre. The cost breaks down to about $120 per month for a Libre. Part of it is that you need both sensors. Well, there's three components to a CGM. You need a sensor, which is what actually attaches to your skin and goes into the subcutaneous tissues to register the glucose. You need a transmitter, which sits on top of the sensor and will transmit that information to a device that is called the reader, which actually gives you the information. Now, most of the time, you can use a cell phone as the reader. But initially, the FDA required that all CGMs be provided with a reader. That has kind of lessened over time as the cell phones have become the readers for most people. But sometimes you have an elderly patient who doesn't have a smartphone, and they will need to purchase the reader as well. So Freestyle Libre, it's about $75 for the reader, and then $60 for sensors, but you need two sensors per month. So that's where you get to the $120 per month. The Dexcom G6 is probably the most expensive on the market, but there are some arguments to say that it's the best on the market. And that comes to about $715 per year for transmitters, which you need a transmitter every 3 months. And then an additional approximate $350 per month for sensors. And then if you have the one-time reader, cost of $400. The third one, Medtronic's Guardian Connect, is about also $750 per year for a transmitter that is a reusable transmitter that can be plugged in and recharged, and then another $250 per month for sensors. The last one, the Eversense, I'm not as sure of. It's a very different CGM from the other three in that it's implanted underneath the skin. So it's kind of somewhat like the Nexplanon, where you have to go to the physician to have it implanted, but then it's good for 3 months. You'll still have a separate transmitter that will sit on top of that, and then it links to a smart device. There is no reader for the Eversense.
That seems kind of steep. I know medicine's expensive, but that seems kind of steep for a chronic illness.
It is. And so my view on that is for type 1s, you can oftentimes get CGMs covered. And so there's not as much insurance pushback for a type 1. For a type 2, it can be a little bit more complicated to get it covered, but it can also be covered under certain circumstances. So one thing too, I've kind of talked to several patients about this, the possibility of paying for the Libre, even if they're only doing it for a few months, because they get the benefit of seeing how food and how insulin affects their blood sugars. Sometimes when they see that data, it helps them to be better controlled, and it might be worth paying $120 for a few months to be able to see that and form some better habits. In addition, you can also get financial help through the companies themselves to get discount codes that will make these prices less.
I'm sure that's helpful. It is expensive. We've established that, but are there specific criteria for getting a CGM unit?
Yes. So primarily the basic requirements, if you look at Medicare, for example, because we base everything off of Medicare, they will cover CGMs for both type 1 and 2 diabetics. They have to go through Part B benefits. And so most are processed through a DME supplier, like in Utah, through Brigham Health or through JQ Medical. They're not generally covered through pharmacy Part D benefits, but some of the Advantage plans, Part C, could process a CGM through the pharmacy. But the requirements typically are the same, which is you have to be injecting insulin 3 or more times per day or on an insulin pump, and also testing at least 4 times your blood sugars per day. In addition, the patient has to be capable of making insulin adjustments based on the blood glucose results. Lastly, Medicare requires that the patient be seen at least every 6 months to evaluate that they're still using the CGM and that they're altering their insulin decisions based on the CGM data.
So, Dr. Stanley, have you found that most patients who end up getting the CGMs, do you find that most of them like it and continue with it indefinitely, or do some end up doing it for a while and then going back to the old method of finger sticks?
You see both. For example, I have a brother-in-law who's a type 1 who refuses to use an insulin pump and refuses to do a CGM. He runs triathlons frequently, and he feels like that would be cumbersome to have those on his skin. So he does blood sugar checks, anywhere from 6 to 10 times a day, and he does injectable insulin rather than a pump because he finds that that's better for his lifestyle. I've also had patients who will go on a pump and on a CGM, and they'll use it for a few years, and then they'll get tired of it and want to go back to shots and blood glucose testing for a year or 2 or 3, and then they come back to the pump and the CGM. So I think it's kind of individualized on what works best for the patient. You can be well controlled with either method.
So how often do you have to change these? Does it depend on the device that you use?
It certainly does depend on the device. So for example, the Freestyle Libre is a 14-day sensor. So every 14 days, you'll have to change out the sensor. The Dexcom G6 is a 10-day. So every 10 days, the sensor's changed out. So 3 times per month. The Medtronic's Guardian Connect is, I believe, a week. I might be off on that one. And then the Eversense is every 3 months. But once again, that's going to be in the office to be changed out.
So you mentioned about I think your brother doing triathlons. How does it work for people who are boating or vacationing or even daily bathing? How does that work? Can these sensors and transmitters touch water, and what kind of precautions do you have to use?
So they are waterproof. Most of them are good for 1 meter for 30 minutes. So that's the Dexcom and the Guardian and the Freestyle all recommend 1 meter for up to 30 minutes. Reality is they will last longer underwater, but the companies that make them don't want to certify them beyond that. Certainly they are waterproof for a shower, for bathing. They are somewhat temperature sensitive. You could go in a hot tub, but you wouldn't want to spend extensive amount of time in a hot tub with these sensors, or they may stop working at least for a time frame while they recalibrate again. They also, when you place them, you need to place them away from pump sites for insulin pumps, away from waistband, from scars, tattoos. You avoid bones as well. They are affected somewhat by insulin repellents and sunscreen, so you'd want to avoid putting those on them as well.
So speaking of, you mentioned about the insulin pumps. Do the CGMs talk to the pumps? Is there a way to connect those two?
So there are a couple of them that will talk. So the Dexcom G6 talks really well to Tandem T-Slim X2 pump, and the Medtronic's Guardian 3 Connect talks to the Medtronic's pump. And so the pump itself can be the receiver in those situations. Also, the Medtronics was the first one that used the data from a CGM to alter basal insulin delivery. So it can slow down delivery of basal insulin if the pump senses that you're going high, or and turn it back on as the blood sugars recover. In addition, the latest one, the Dexcom G6, as of January of this year, now has what's called Control IQ, where it will both decrease your basal insulin if you're running low and increase your basal if you're running high, and also is the first one that's approved to bolus insulin if you are going too high.
As the patients are seeing these readings that are going too high, they don't have medical training, so how can they really interpret them, right? Can physicians or clinicians use the at-home CGM readings in clinical decision-making, or is this just something that you kind of take with a grain of salt?
So this is something that's really exciting in the field, is that these CGMs will talk to your cell phone, but they can also talk to your physician. They can also talk to a parent. So if you've got a child who's on a CGM, their parents can get the reading at 2:00 in the morning that their child is either running too high or too low, and then they can react to that data. In addition, the physician's office can be hooked up to it too, so there can be automatic downloads and the data can be seen from afar.
That sounds really cool. Like really cool. It's like Star Trek kind of stuff. Now, so what kind of information does a CGM reading provide the clinician besides just a blood sugar reading?
Yeah, so one of the things that is a real advantage of having a CGM is When you get individual blood sugar readings, you're getting a single data point in time. When you get a CGM reading, it can take into account direction and velocity. So most CGMs will come with, when you look at the reader and you're looking at the report, it will not only tell you what your current blood sugar is, but it will also give you a direction and a velocity. So it may say that your blood sugar is 120 and rising slowly, or 120 and rising quickly, or 120 and dropping slowly, or 120 and dropping quickly. That allows you as a patient to make decisions on where your sugars are going, and you can react before they get too high or too low. So that's one of the biggest advantages that you have with a continuous glucose monitor is the velocity direction.
So I know that most physicians, I think, are sort of driven by efficacy studies and data, and so are insurance companies. So is there any good studies out there that demonstrate benefit from diabetics using CGMs versus finger stick?
So there are good data. So one of the data is that A1C reduction in type 1 diabetics with a CGM shows a decrease of 0.6 to 1%. Also for type 2s, it's 0.3%, both of which are better than self-monitoring of blood glucose. They also lead to a decrease in hypoglycemic events and an increase in quality of life because patients feel more freedom when they have a continuous glucose monitor because they know where their sugars are going rather than guessing at it based on a data point from a few hours ago.
Is there a relationship between those who do the strict CGM monitoring versus kind of relaxed CGM monitoring and hemoglobin A1C values?
So A1C definitely does decrease with CGMs versus those that do just self-monitoring of blood glucose. Now, like always, the patient that's more involved, the patient that is more aware of what their sugars are doing and will react to those sugars are always going to do better than those who are more lackadaisical.
Any kind of test also involves some sort of potential inaccuracies, whether it be blood pressure checking or rapid strep tests or flu tests and so forth, false positive, false negatives and such. So what is the chance of an inaccurate reading with the CGMs?
So that does happen. One thing to remember with a CGM is it's not measuring capillary blood glucose. So when you do a finger stick, you're measuring capillary blood glucose. When you're using a CGM, it's measuring interstitial glucose, which is slightly different. There is a slight delay in between the two as well. So one thing too is a lot of these do need to be calibrated. And the two that do not need to be calibrated, that are factory calibrated before they're used, is the Freestyle Libre Flash and the Dexcom G6. They do not require calibrations unless the sensor itself is registering out of range, and then it may ask for a glucose calibration. The Medtronic's Guardian 3 Connect and the Eversense both have to be calibrated every 12 hours. So you can't quite throw away your blood glucose meter just yet with any of these. I find that I calibrate in the first day or two of my sensor, but I find that after that, I don't need to calibrate anymore. So maybe in a 10-day time period, I might calibrate 2 or 3 times. But you also do have to calibrate if you ever sense that your result is not measuring up to how you feel. For example, if you feel like you're having a low and your blood glucose monitor says that you're fine, that you're 140, 150, it's time to calibrate and make sure that you're getting the accurate reading. Like always, you still rely on how you feel over what the monitor tells
you. Yeah, kind of just what you were saying. That's one of the big fears that I have about taking my laboratory tests out of my laboratory and taking them in the home. And it's nice because of the convenience, but it does mean that we can't really trust the values as much.
Most of the time, my capillary blood glucose matches up within 10 points of the continuous glucose monitor, which really bodes well for what the monitors are capable of doing these days. The accuracy has gotten better and better over time. And the very fact that you can go 10 days without calibrating, that's pretty impressive. That says that the data is pretty good that we're getting out of these machines.
That's really good to be able to match within about 10 points. And that's consistently at the high end of the spectrum and the low end as well.
That for me personally. Now, sometimes it may be off by more than that. And particularly as testing, you want to test more often until you know that you're comfortable with the readings that you're getting out of the machine.
So that's with the interstitial and the capillary. So what about, have you done a comparison between, the interstitial fluid and, the serum glucose analysis that's done in the hospitals?
So serum glucose analysis is still the most accurate. The second most accurate is either capillary or interstitial fluid.
So you had earlier mentioned about the criteria. This is a similar question, but maybe a little different. Is who do you think are the best candidates? Who are the patients that you see in clinic that you talk about this and encourage to get a CGM?
That's mostly important when in the hospital setting. In the hospital setting, you're always going to rely on the serum over the capillary blood glucose. So honestly, all patients with diabetes would benefit from a CGM. If cost was not the issue, I would recommend every diabetic be on a CGM because I think you get so much more data. For example, if you're testing even 10 times a day, which is pretty aggressive for self-monitoring of blood glucose, you're not coming even close to what a CGM does because the CGM registers a blood glucose every 5 minutes, which means in 24 hours, you get 288 readings, significantly more data points than you get with 10 pokes in a day. And most diabetics test 1 to 4 times. So you're significantly increasing the amount of data. Anybody who has a risk of hypoglycemia, particularly the Dexcom G6 and the Medtronics, and even the Eversense have alarm systems. So if you're dropping too low, they will alarm before you drop too low so that you can do something about it before you get to a hypoglycemic unawareness. It's also great for somebody with low dexterity and low vision because you can blow it up and see the results quite easily, better than you can on a handheld monitor. Anybody on an insulin pump would benefit from a CGM because particularly the newer ones that are linked to the pump technology. There are maybe some also who struggle with finger sticks. For example, a mechanic who often has dirty hands may not want to be poking a needle through his dirty fingers. Also, a flight attendant who doesn't want to risk blood exposure to those that they're servicing on the plane. And then also young children who are dependent on parents or caregivers to provide their care. They certainly would benefit from having a CGM.
You just mentioned hypoglycemic episodes. And those are kind of scary for me. Since CGM reduces hypoglycemic episodes, is there really a survival advantage to having a CGM placed over traditional glucose monitoring?
So we don't know specifically that there is a survival advantage. We know, for example, in the hospital setting, somebody who's using a CGM, you're going to detect more hypoglycemic episodes. But that's probably just because you're getting more data. So in the patient you're checking 4 times a day, what are the odds you're going to pick up the hypoglycemic episode versus somebody who's on 288 readings a day? You're far more likely to pick that up. Well, I don't have specific data. It would make sense that it would have a survival advantage.
I imagine there's not a lot of complications or downside, but can you think of any complications, negatives, side effects of having a CGM? Such as infection rate, inaccurate readings? What would you say some of the complications are?
Some of the complications, you do have to be a little careful with things like x-rays and CT scanners and MRI machines. The CGM should be taken off for any of those events. In theory, you could have them covered for an x-ray, but for a CT or MRI, for sure, I would remove the CGM prior to doing that procedure. In addition, when traveling through airports, the CGMs are not, and the equipment for them are not supposed to go through the scatter plot scanner. They can go through the walkway x-ray machine, but they shouldn't go through the scatter plot. And the devices should not go through the airport screening machines. They have to be hand evaluated by the screeners at the airport. As far as infection goes, they rarely do cause infection. I have had one of my CGMs get infected, where I had a low-level infection on my arm for a few days until things settled down. But for the most part, they rarely do become infected. You can have allergic reactions to the adhesives that are used. And so some of the time you can pre-treat with Flonase, Fluoroplast, or Cavalon barrier to help with allergies to the adhesives. And sometimes if you're particularly going to be sweating a lot or you're going to be swimming a lot, then using a product such as Skin Tack or Mastisol can help the devices to stick longer and better. Some of the companies also produce over patches that help the patches to stick better and to last longer as well, so they don't come off as frequently.
Is a doctor prescription actually required for getting a CGM? I assume it is for if insurance is involved, but otherwise, can they get it without?
You still need a doctor's prescription to get on a CGM.
And you mentioned on your arm, I've seen lots of people, especially like teenagers with them on their bellies, but where on the body is a CGM typically placed?
So every manufacturer has different requirements for where they're placed. To my knowledge, the Medtronics can be placed on either the abdomen or the arms. The Freestyle Libre is indicated for the arms primarily. Dexcom G6 is only indicated for the abdomen in adults, but it can go on the upper buttock in a child. And Eversense are typically placed in the arm. Now, that being said, like always, we do off-use things with ourselves. I have found that my Dexcom G6 does just fine on my arm. I get the same readings as I get on my abdomen, and that saves my abdomen for my pump sites for my insulin pump.
So have you tried more than one or even all of these different devices, or have you just had the one so far?
So I have used the Freestyle Libre. I've also used the Dexcom G6, and I've used the Medtronics Guardian. So I've tried 3 of the different ones. And I found that they all work just fine. The Freestyle Libre and the Medtronics, of course, have to be calibrated twice a day, where the G6 does not. So I find that to be an advantage.
Now, in the future, do you see CGMs becoming the norm? Or do you think the finger stick glucose will always be the most common method, like kind of like the go-to standard method?
Because of cost, the finger stick glucose is still going to be the standard method. However, as CGMs become more plentiful and cheaper, I do think it's a better way of controlling blood glucoses. It's kind of a different way of looking at glucose too. You know, the goal with a CGM is to have 70, we start talking about time in range. So, which is a whole different concept, because rather than looking at an A1C, which is this average measurement of 3 months, we get time in range, which can be looked at from a day-to-day basis. So the goal for CGMs is to have at least 75% of your day spent in range, and that's generally from 80 to 180. And then you want to have less than 5% low, and less than 1% critically low. And then also you want to have less than 20% in the high end zone. And so we can start looking at diabetes in a very different way when we start looking at CGMs, and we start looking at time and range. So a patient who might have large fluctuations might have a good A1C, but if they spend a lot of time really high and a lot of time really low, their average might look good, but they're really not in good control. But if you look at time and range and most of their day is spent in range, that may actually be better control than somebody with a better A1C.
How about the elderly population? Do you see a lot of elderly folks using CGMs?
I typically don't. However, with Medicare now approving them if they're meeting criteria, we may see more elderly people using CGMs, particularly type 1s. The recommendations, if a type 1 has been well controlled on a CGM, just because they turn 65 and go on to Medicare, they shouldn't lose their good control. And so I think we will see more elderly patients use them as time goes on.
I mean, you talked about kids earlier and you said they could be used on the buttock, but I have 3 kids myself and they don't keep masks on for COVID. So how do they keep these on?
Over patches certainly make a difference, and they have fun styles of over patches that have kids patterns that make them fun, like a Band-Aid is fun to a kid. And, interestingly enough, putting on these sensors, the needle looks pretty intimidating if you just look at it, but actually applying the CGM, there is very little pain. In fact, I think the finger sticks are far more painful than applying a transmitter or a sensor. And so I think for most kids, once again, when they realize that it's either this or multiple finger pokes per day, they would take this in a heartbeat.
Do you keep test strips and lancets with you as backup and travel with those?
For sure, with travel, you need to have extra sensors, extra transmitters. It's just nice to have the extra when you travel, because you just never know what might happen. And occasionally these do come off. With an activity, you might bump it off or might hit it off, or the tape might not hold up. And so you always need to have extra backups. In addition, you should always still have blood glucose test strips and a glucose monitor, just because if you do lose your last sensor, you still need to be able to know what your blood sugars are doing.
We talked about this a little bit before, but for hospitalized patients, do nurses and physicians use the CGM to get glucose readings like inside the hospital, or do they just use finger sticks instead? Like if a patient has a CGM in the hospital.
There is still inconclusive evidence for widespread use of CGMs in the inpatient setting, especially for critical care. And, as I mentioned, they do have an increased number of hypoglycemic events, but that's probably just because they're being detected more often. My take on it is if I've got a patient who's in the hospital who has well-controlled diabetes, particularly if they're a type 1, and they are on a continuous glucose monitor, there's really no reason other than x-rays, MRIs, and CTs to remove the CGM. And that way the patient is able to self-monitor. Now, this should be primarily only done with a patient who knows is still conscious and coherent and able to interpret their own data and able to calibrate when they need to, and able to use that information to adjust their own insulin pump or their own levels. But it needs to be done in coordination with hospital policy, the nursing staff, and the doctor who's involved with the case. But if you've got a patient who's well controlled, well managed, who knows what they're doing and is coherent enough to take care of their diabetes in inpatient setting, by all means, they should continue to do so, rather than we as doctors thinking we know what's best for that patient who manages it all day, every day, and we manage it for a few hours in the hospital.
Do you think that most nurses in a hospital know how to use CGMs, and will they use those data points to chart results, or will they still stick with finger stick results for charting purposes?
So most nurses do not understand CGMs or how to use them. And so I think it needs to be a collaboration between the nurse, the doctor, and the patient when you use a CGM. I recently had a type 1 diabetic patient, teenager, who was in DKA, and she did have a CGM and an insulin pump, and we did employ the CGM and the insulin pump. We did some calibrations to make sure things were correct while we were in the hospital setting, but we used that data to help us make the decisions for this patient. It was satisfying for both the parents and the patient and the nursing staff to have that additional data point.
Is it a similar situation in nursing homes, or do you see that as a different situation?
I think at a nursing home, I think it would be less advantageous to have a CGM. At that point, when we're talking end of life care, the patient may or may not be coherent enough to manage their own CGM and their own glucose levels. And at that point in time, I think maybe going back to self-monitoring of blood glucose might be the best way. As time goes on and we get better studies, we might start seeing CGMs used more in the nursing home setting, however, because then we get the additional data points and we can better manage the patients. But it doesn't involve intensive management to use that data to its fullest effect.
You talked about how you transitioned from diagnosis of type 2 to type 1, but you're still on metformin, aren't you?
I am. So I'm doing several off-label things, which is kind of fun for me because as I've done my research, I've learned a lot. So one of the interesting things is loopers. That was one of the interesting things for me. I went to a type 1 diabetes conference and learned about looping. And this really isn't part too much of CGM, but loopers are people who wanted to have their own pump CGM combination where they would take what's called a Riley link, which talks between the pump and their continuous glucose monitor and their cell phone, which allowed them basically to come up with their own automated pancreas, which basically would automatically bolus and automatically slow down the boluses of insulin according to what their blood sugars are doing. But it gives them full control. I'm on a hybrid system, and the hybrid system still helps to control the goals, but it's pre-programmed. So there's an exercise function that maintains me about 150, and there's a sleep function that maintains me about 112, but I can't change those parameters. The loopers can actually change those parameters and put exactly what they want in. It's not FDA approved, and they do run some risk of hypoglycemia or hyperglycemia because they're not using an FDA approved product, but it was an interesting concept to me of looping. But the hybrid systems are actually pretty good, and they're kind of doing the same thing, but FDA approved. But I'm also on, so I thought about looping, but now that I've got a hybrid system, I'm good with that. I'm also still taking liraglutide. I'm taking Farxiga, dapagliflozin, and metformin, all off-label. There is some data in the type 1 community that those are drugs that can help. The dapagliflozin, they've looked at the FDA 3 different times, 3 different SGLT2s, and the biggest problem is it increases the risk of DKA in a type 1. And you can go into DKA even a blood sugar of 200, which makes it a little scarier to use. But since I spend very little time above 200, I'm not as worried about using it. And and it's, once again, has some heart protective effects and has some weight loss effects that make life simpler. And there are a lot of type 1s who are using SGLT2s as well as GLP-1s to help with their control. And then, of course, the metformin just still makes the insulin you take more effective. So the bottom line, the net effect of using a pump and using these other drugs is that I use less insulin in the long run.
That's really interesting. I never considered taking, being able to just kind of play with your drug regimen like that, but I don't prescribe drugs. So that's why.
If you look at every year, the American Diabetic Association comes out with the guidelines for diabetes and how it should be managed. And these are drugs that they have looked at for type 1s. So they're not recommending and they're not discouraging. They're just saying it's something we're looking at.
Hey, I've got one more question for you, Dr. Stanley. If you as a physician and also having diabetes, you're in a unique position to really educate and train patients on using CGMs. But for someone like me who's not diabetic and not familiar with the technology, what are some resources? I can do the prescription for the CGM, but what are some resources for getting that patient educated on how to use it?
So, certainly clinical pharmacists can be quite helpful. In our clinic, we have a clinical pharmacist that we can refer patients to who can go through the procedures to make sure they do understand how to use a CGM. The manufacturer's information that they send with the CGM is actually pretty user-friendly. It would take a lot to mess it up. If you follow their instructions step by step, it's printed in bold, big type. It's not too hard to follow the instructions to get them correctly inserted and use the data. In addition, I failed to mention that there are apps also that the CGMs will talk to. And using those apps, you can get a really clear picture of what's going on with data. For example, with my Dexcom G6, there is the Clarity app, which will overlay all of my blood sugars for 90 days. It will come up and tell me what my A1C is likely to be. It will also tell me what trends I'm having, if I'm having times of day when I tend to be higher or lower, so I can adjust my basal insulin according to what my 90-day readings are. And so it's really good to see your average blood sugars and what you're actually doing in real time.
Dr. Stanley, I'm so grateful that you were able to come here and teach us about what CGM is, continuous glucose monitoring, and how you use that personally and also professionally. It really provides us with a great perspective. So thank you very much. I wanted to thank you.
You're welcome. I love this technology. I'm glad it's there. I feel like I got diabetes at a good point in history when this newer technology is available, and it does make life easier.
That's a really good way to look at that. And if we could also take something from you, take your perspective, I think we'd be well served. Your producers for tonight were Clark Madsen, MD, MS, Teresa Puskedra, MPC, and the board of the Ogden Surgical Medical Society. Your executive director is Teresa Puskedra, MPC. Your hosts were Mark Johnson, MD, and me, Scott Moore, DO. Your editing and sound design was done by Colton Gomez, and this is all supported by members of the Ogden Surgical Medical Society like you. Thank you.